My respected teachers and friends, it's indeed a pleasure actually to have Dr. Mohan Ramchandani, who has been our own student, and he has become one of the most important interventional endoscopists of not our country, even the Southeast Asia. He is working with the AIG, which is considered the best institution as far the intervention endoscopy is concerned, not our country, in whole of the Southeast Asia. Dr. Mohan Ramchandani passed out from 2005 from our place, though he had undergraduation and postgraduation from Bhopal. And to his credit, he must have published more than 60 papers, in all were very standard, general, with very high impact factor. His area of interest basically is not only the biliary endoscopy or pancreatic, he is expert in the endosono, and nowadays the POI, which has become a standard treatment for the achalasia cardia, he is a master of that. So today it's our really indeed pleasure to have Mohan Ramchandani. Now he is going to talk on the endoscopic treatment of obesity in our center. As you know, this obesity has become real problem, and pharmacotherapy doesn't have much of the role except the lifestyle modification. And then bariatric surgery has also become one of the important tools, but that is again with the more of morbidity. So definitely endoscopy remains one of the very important option with even less morbidity and mortality, which can help us in reducing the obesity. Dr. Mohan Ramchandani.
Thank you, Dr. Dixit, for your kind words and respected teachers. First of all, I thank the organizing committee, Hemant and Monica, for giving me this opportunity. Actually, I am working as a super specialized hospital, and I have developed a narrow vision, and I thought everything can be treated by endoscopy. But today, here in the galaxy of speakers, speaking about this metabolic syndrome, the psychiatric aspect, and the endocrinology aspect, I thought this is a very, very small tool to treat this, and the preventive options are one of the best options available. And I was very delighted to hear Professor Tripathi talking about microbiome, and the type of water we are drinking, which is leading to this type of syndrome, was much important than treating this massive disease with a small endoscope. Nevertheless, since I know only this thing, so I will just speak few words about this, and then let us see what I have to offer as an endoscopist for this morbid disease, which is now classified as a chronic disease by WHO in 1997, and it contributes significant to the mortalities. And as you see the BMI going high above 35, there is an exponential rise in the mortality. And not only the world, India is also now moving towards epidemic with around 10 to 20% prevalence, leading to an epidemic proportion. And these are the things to come, leading to many complications which we have already learned about: pulmonary disease, the gynecological problem, PCOS, cardiovascular disease. Pravir spoke about the NASH and all that. These are the things which we have to deal once this patient develop metabolic syndrome, and we as an Indians are much the and lot has been talked about the genes which causes us more prone for visceral obesity, and that's why the Asia Pacific authorities have decreased the threshold for class 1 obesity from Western world to 35 to now only 25. So it makes almost all of us present in hall as a class 1 obese. And the treatment options which are there are medical, but as Pravir told us that these are very minimal options available over here. The problem with surgical is that it carries a high morbidity, but there are a lot of now improvement happening in this field, so probably this figure is slightly high, which is gradually coming down. But nevertheless, we have an endoscopy which can act as an option in patients who have medical failures, or those who want to do this surgery but they are still unfit, and can act as a bridge to the surgery. And the positive point is that it has got very low morbidity, and also the effectiveness is there. The disadvantage of certain surgery is the mortality rate and the post-operative complication. While the advantage of endoluminal therapy is that it is ambulatory, it is safe, It can be a pre-operative or it can be a stand-alone procedure to reduce the weight. It is cost-effective, and extension of indication to mild obesity is also there, which can be slightly morbid for a surgical option. For endoscopic treatment, we basically have two therapies. One is restrictive techniques, where we restrict the volume of the stomach by either putting a space occupying thing over there which reduces the capacity of the stomach by putting intragastric balloons, or we can endoscopically reduce the volume of stomach by plicating the wall, or we can create a malabsorptive technique by various techniques which I will just touch upon. So the first thing which started was intragastric balloons, which the BIP balloon, which was very famous, was the first balloon to be introduced, and later on many balloons are introduced. This is how we put a balloon. This comes in. These are not through the endoscope procedure. These are by the side of the endoscope. You have to put. You can put through a guide wire, or you can put blindly also. And then you need to just it has a balloon which is deflated at the distal end of a tube, and this tube is passed inside the stomach, and then you have to put this saline filled with around 700 to 700 ml of saline. There is a blue color saline. This is a methylene blue in it. Why methylene blue? Because these gastric balloons are prone for rupture, and if they rupture, they travel into the small intestine and cause obstruction. So methylene blue, if it is released in the stomach by rupture, it is absorbed and excreted by kidney. It turns the urine into green one, and then patient can know prior that the balloon has rupture and can immediately take a medical help to remove this ruptured balloon rather than land up into major troubles. So this is how a balloon is placed inside the stomach. And once the balloon is placed, it occupies majority of the stomach and reduce the volume of the stomach. You can see this is the air in the stomach, and it has almost occupied 2/3 of the stomach. And the studies have shown that if you push this balloon for 6 months to 1 year, there is a significant weight loss. And there are many balloons available. The problem with this balloon is that it causes distension of the stomach. Patients are not able to either tolerate it, or sometimes these balloons are of inadequate volume and the patient may not have an adequate weight reduction. So there is an adjustable balloon system which has got a catheter which can brought out through an endoscope outside, and depending upon the patient's symptom, whether he is gaining or not gaining weight, whether he is tolerating or not tolerating, you can increase or decrease the volume of this balloon. This is known as a Spatz balloon, and it is approved for placement of 12 months. So what is the present literature which says that intragastric balloon for weight loss? There are the results of around 100 individuals for at least 2.5 years, and it says that intragastric balloon therapy is relatively innocuous and associated with successful weight loss and maintenance at 2.5 years in quarter of patients. So almost 1/4 of patient can maintain for 2.5 years, and it represents a valid option for weight loss. So it is not only the volume which is reduced, but it also brings in some of the hormonal changes in the body, and which will lead to many physiological changes, and also ultimately prove to be effective in weight loss. The majority of the weight loss, excess weight loss, is around 30 to 50%, especially if you put these balloons in non-morbidly obese patients. But those who are morbidly obese patients, they have not that much weight loss, or pre-operative also is slightly successful, but most of the time it works when there is a non-morbid obesity, and you can put the balloon which can cause substantial weight loss. The complication of balloons are not much. The most common are nausea and vomiting, which may cause removal of this balloon, but the gastric perforation and balloon deflation, which are the most serious complications, occurs very, very infrequently. So this was one of the technique where we put a space occupying a device which reduces the gastric volume. We can also restrict the stomach volume by plicating So now there are many plicating devices available. The initial was endocinch, but the problem with this was that the sutures were taken from submucosa. So when there is a sutures are taken from submucosa, this anterior and posterior wall of the stomach was approximated, and it creates a small stomach tunnel which increases the satiety. But the problem with non-full thickness suturing is that it gives way and ultimately it opens up. So now we are having a full thickness suturing system. This is an Apollo stitch device which approximates the stomach wall full thickness. That means serosa to serosa suturing can be done and it stays long. So the studies are going on which are evaluating what is the role of. This is now just an endoscopic sleeve gastroplasty, which is exactly what it is done in surgical method, and these walls are approximate serota, but results are awaited. There are many other restrictive technique, and this is the pouch. This is a technique where barosense transoral platform where the sutures are created, and there is a gastric pouch creation. Those who have seen the surgery of this bariatric surgery, where a pouch is created in the stomach, in the gastric cardia, and rest of the pouch is excluded. But in this, this pouch is created, and this acts as a reservoir, and the food is slowly passed down, and the satiety can be achieved very early. This is known as barosense transoral platform, and this is an innovative technique, and the early results have shown that there is around 20 to 30% excess body weight loss. Transoral gastroplasty is another technique where similarly anterior posterior walls are approximated by various different techniques. Full suturing, full thickness stapling is done, and it creates a tunnel. And once they create a tunnel, the food passes slowly, and this much of stomach is excluded, and it gives early satiety. And this has also shown important endoscopic method, but unfortunately this company has gone into bankruptcy, and then the production was stopped. What about the metabolic endoscopy? So this was about the restriction or exclusion, but here we are talking about endo barrier. This is a metabolic endoscopic device where you can place a polythene sheath which covers the duodenum and the proximal jejunum, and food is not allowed to mix with the pancreatic or biliary juices up till to the distal jejunum. And so it is a malabsorptive procedure, and this is how it is done. Endoscope is passed, a guide wire is passed into the jejunum, and then we have a capsule which has got a sleeve inside it, and then once the sleeve is there, it is done not through the scope, it is by the side of scope. The sleeve is passed into the intestine, it covers the proximal intestine, and then it is inflated over there by passage of fluid, and then it snugly becomes a barrier between the food and the absorptive surface of the duodenum. The problem here was this anchoring device. So these are the wired device, and it can sometimes cause liver abscesses. So this device also has gone out of the market, but people are now developing the anchoring system. Though the sleeve remains the same, but this anchoring system is now being developed into a different way, which is more safer and easy to remove. But the studies have clearly shown that if you put such type of sleeve for at least 6 months to 1 year, there is a decrease in HbA1c at week 30. So the HbA1c is significantly reduced if you put endoperier versus sham treatment. So concept is there, but the device is being developed to reduce the complication. The other device, this device was to put the sleeve from pylorus into the duodenum, into the jejunum, but people are now working to put this sleeve from the esophagus, the GE junction. So if you put the sleeve from the GE junction up till to the jejunum, and now this is a slightly difficult device to be put. sometimes may require a laparoscopic assistant, and this is known as Valent TX, and this is another method of, it's just similar, but the proximal end of the sleeve is anchored at G junction rather than into the pylorus, as we see. And this study also have shown that the BMIs of 37 to 50 were included, and early results are promising, some with 46% mean excess body weight loss, but too early to say, very less number of patients, we require more data. Now, the metabolic endoscopy is now evolving to a different level now. It has been shown that if your Western diet is there, which is rich in fat and sugar, it causes intestinal hormonal changes leading to, because of mucosal hypertrophy and changes in the gut hormone. And this leads to an organ effect on the periphery, that is impaired glucose tolerance and insulin resistance, and this will lead to beta cell failure and type 2 diabetes. So this is now, the research has clearly shown that there is abnormality in the proximal intestine, especially the duodenum. There is mucosal hypertrophy and changes in the gut hormone. And this is well known incretin and anti-incretin theory, where surgical colleagues have clearly shown that if you exclude the duodenum and you do a bypass where the food is directly delivered from the gastric remnant into the distal jejunum, there is improvement in the incretin and anti-incretin balance, leading to normalization of diabetes. So this has been also shown by many studies, where there is a different level of hormones into the duodenum. So it is like a computer catching a virus, and once you reprogram it, that means if you format it, that means you completely make it new, it helps. So this is similarly known as duodenal mucosal resurfacing. So if you remove all the mucosa from the duodenum and then allow it to resurface, the diabetes may improve. And this is known as DMR. This is the method, how it is done. There is a balloon over there which is passed into the intestine under guidance. Once we go into the duodenum, we pass a balloon which is filled with hot water. First of all, only mucosa and submucosa needs to be treated. So the mucosa and submucosa are lifted by injection of the saline. The muscle is left behind. So there is a separation which is being, this is known as lifting, where the saline is being deposited between mucosa and the muscle, so that whatever you do to the mucosa or submucosa, the muscle is not damaged. So similar elevation is achieved throughout the duodenum by endoscope, and once you separate out this mucosa from the muscle, you pass another device which has got hot water, and once the hot water is passed on this mucosa get damaged. So whatever the hormones which have gone wrong because of the Western diet, because of the new diet, there is an imbalance between incretin and anti-incretin is totally gone now. This is similar to doing a metabolic surgery where you are excluding the duodenal mucosa. So here you are burning the duodenal mucosa and getting rid of that imbalance, and then ultimately you will achieve, this is an endoscopic view, this is the real-time view, how it is being done. This is the saline is being injected into the duodenal mucosa, and see how well the mucosa has been lifted by injecting saline. And once you, it is being burned by a hot balloon. So this is the balloon filled with very hot water, and then you achieve this type of burning of duodenal mucosa. And once it is done, there is no harm to the patient, because 1 month follow-up, everything comes down to normal, and 3 months follow-up, everything comes back to normal. There is some chances of duodenal strictures, but the results have shown that this type of mechanism, duodenal mucosa resurfacing, improves fasting and postprandial glucose level, and there is significant drop in HbA1c, the fasting blood glucose, and more the length you burn, better is for the patient. This has been shown, and a lot of studies being done in this regard. Botulism toxin has also been tried, but the injection of Botox in antrum and fundus, the mode of action is that it reduces the antral motility and gastric emptying, but the results are variable. What are the other new endoscopic treatment? Now the gastric or jejunostomy, the bypass is being done by using magnets. You pass magnet into one loop of intestine and pass another magnet from other end to the different loop of intestine, and leave this. The two magnets will join and ultimately create a passage which will be like after the pressure necrosis, there is formation of jejunostomy or jejunoileostomy. So the weight loss is now being treated in many ways. The efficacy is always directly proportional to the invasiveness. The drugs are least invasive but least effective also. The Roux-en-Y is more invasive, though it is the most efficacious. This surgery is no doubt is far ahead than other management, but we have also to see the invasiveness, and the barrier devices and endoscopic treatment have intermediate type of efficacy, but they are much less invasive also. So endoscopic in present era therapy of obesity can be as an early intervention, and it provides weight loss or stabilization in early stage obese patients who have not yet qualified for traditional surgery. And you can use Botox toxin like this. It can act as a bridge to the surgery, and it reduces the obesity related operative risk for various bariatric and non-bariatric surgery, and you can use a simple balloon for that. Metabolic, like primary addressing the comorbid illness, diabetes is definitely, and I already told you about this sleeve thing which can be easily placed, and there are now many new development of anchoring system is occurring. It can act as a primary treatment, like endoscopic option for traditional surgical population with outcome and risk profile similar to current surgeries, and that includes like toga or as endoscopic sleeve gastroplasty or full thickness suturing. It can help in revision, repairing the failed bariatric surgical procedure. We see many patients of gastric leaks can easily be treated by endoscopic method. So treating such patient is a multidisciplinary approach. We require psychiatrists, gynecologists, orthopedicians, anesthesiologists, and so on. So the present, this is my concluding slide, and who qualifies for the weight loss surgery procedure. Those who are having overweight, they need to be put on diet. Those who are between 30 to 35 can be treated by endoscopy, but gold standard still remains the surgery. But endoscopy is a very important bridge to these people. Thank you very much for your listening.